Good morning, everybody. Let's go ahead and get started with today's session. We have a lot to cover in the next 1 hour. For those of you, if you could mute yourself if you're not speaking, that would be great. For those of you who are new today, welcome to the joint Johns Hopkins University India USAID RISE Project COVID-19 case discussion series. This series is really generated because one of the challenges with COVID-19 has been the plethora of information, and it's been so difficult to really understand what is the current recommendation. Not only has the virus evolved, but our knowledge of the virus has evolved, and there is so many people with opinions to share. So together with Johns Hopkins University, we are bringing to you the experts. Today, we are featuring AIMS Bhopal and Dr. Rajneesh Joshi and Dr. Gautam, who will be presenting a case. And then from the United States, Dr. Paul Auwaerter. Next slide. So the focus, we have an interesting way of doing things. We're going to start off with an introduction today from Dr. Singh, who's welcoming us to the session. We'll talk about a case in India and some of the therapeutic challenges through that case. And we'll have a panel discussion, and everybody here is welcome to participate in the panel discussion, where we will discuss current questions that you're facing in the clinical area. And we'll wrap up with a 15-minute focused evidence-based review from Dr. Paul Auwaerter, who at Johns Hopkins University is our leader in terms of therapeutic guidance. Next slide. So before we get started, I want to run through a couple of welcome introductions and acknowledgements. Next slide. And firstly, I'm going to hand over to our keynote address, Dr. Prof. Sarman Singh, who is Director and CEO of AIMS Bhopal, who has kindly joined us today on the podium. Prof. Singh, if you could unmute.
Yeah, Bhakti, thank you very much, and so kind of you. And this is evening here in India, so thank you once again having this collaborative work with Johns Hopkins and AIMS Bhopal. We are really privileged that Japaigo and Johns Hopkins University and the USAID, we are working together. We all know that, as you very rightly said, that the COVID has affected whole world, and we know that in last 2020 we were not knowing anything about the coronavirus and the disease it causes. And not only the countries which are considered to be developing countries, but even those who are considered to be highly developed countries, they also realize that there are many gaps in our understanding not only the coronavirus but the disease, its epidemiology, its protocol to treat and prevent. So all these things, they were there. As far as India is concerned, we know that we were having this kind of virus testing laboratory, only one in NIV Pune. And with the help of Ministry of Health, Government of India, and ICMR, which is akin to NIH in the USA. So now we have 2,500 testing laboratories. So this is a really great achievement in made strides. In the same line, other than testing, the Government of India and along with the other institute, particularly the ICMR and Directorate General of Health Services and the AIMS Delhi, they mastered, and then they tried to develop many protocols. But we know that these protocols, they are still developing, and only in last 3 months or so, Directorate General of Health Services, they have developed many good protocols. Before this, even though the hit and trial, many errors and successes, they were there, and many protocols they were developed, and that came out that whether remdesivir or tocilizumab or steroids, and what is being used or overused or misused or indiscriminate use. All these stories we know, and I think this is very interesting, and I am really very happy to say and share with all of you that when Government of India was making source of excellence, just like for testing, they also wanted to have dissemination of the knowledge from Government of India through these centers for excellence in various regions of the country. And AIMS Bhopal is one of the center of excellence to cater the knowledge in the area. And in that, once again, you are helping. So this is a great thing. And let me tell you that, so far I got the data from Dr. Rajneesh, who is coordinator, and I am just a mentor for the Center for Excellence. So we have done 536 doctors we have trained so far. And this includes from the various treatment facilities. That is, number is very good. 81 different COVID treatment facilities in the area of the Madhya Pradesh and around. We have done so far the 33, and this is 34th webinar as far as the information I have got. And through this, because those who are participating as a partner, plus others are also, as you also said that you invited. So these webinars, they are open to all. So if we see that we could engage more than 4,000 participants from various parts of the country, not limited to the area. So I am really, really very happy that we are going to participate. And the protocol, the program I was seeing, so I can see that from AIMS Bhopal, Dr. Rajneesh is leading, and from USA, Dr. Paul is leading. So both are very, as you very rightly said, that they are very well known, ID specialist, and they have done a lot of work in the COVID area. I also see in the list that there are other speakers. My institute also like Dr. Sunena, Dr. Saurabh Saigal, Dr. J.P. Sharma, and also Dr. Lokendra Dave from Government Medical College, Bhopal, along with Dr. Souvik Chatterjee from John Hopkins. So I think this is going to be very helpful. And let me tell you that the time allotted to me was only 2 minutes, so I will not take much time. But definitely, we know that as the case-based teaching is always the best teaching. So I am very happy that this presentation will be in the form of case-based presentation and also in the panel discussion form. So I am really, really very happy, and I am pleased that this is happening, and my best wishes, and please carry it on forward. Thank you very much.
Thank you so much, Dr. Singh, and it's an honor to be here. So I want to introduce some of the people in the background that are making this possible. First of all, Dr. Bulbul Sood, a Senior Strategic Advisor at JPIGO, Dr. Sumesh Kumar, Country Director at JPIGO, and Dr. Vineet Srivastava, who is our Chief of Party for the RISE project. So it's these individuals who are working together with the United States government, next slide, to bring to you not only this case discussion series, but numerous interventions for COVID-19. This includes upscaling laboratory capacity, using innovative methods to build networks, stratified case management, vaccine micro-planning and support, and many more. So if you have any questions about JPIGO and our role in supporting India through the pandemic, please reach out to those individuals. And this JPIGO RISE project is fully funded by the United States government through USAID. We could not have done this without Dr. Sangeeta Patel, Dr. Amit Shah, Cynthia Ger, and Dr. Vijay Paul, who have been instrumental in advocating for India to be prioritized when it comes to funding, but then also helping design a strategy and a technical assistance that isn't just this webinar. This webinar is just a small piece of a very big puzzle. Next slide. And then from Johns Hopkins University, in the background, you're going to meet Dr. Valerie Osula, Dr. Pavna Seth. So after today's session, there'll be a comprehensive document that includes a synthesis of all the case studies that were mentioned today. And your facilitator and guide for today's journey is going to be Dr. Souvik Chatterjee. Dr. Chatterjee is a medical director in the intensive care unit at Bayview Medical Center. He's also an expert in medical education and a master educator. And like me, we're both of Indian origin, and we are excited that from afar, we're still able to support a country that's very near and dear to our hearts. And Dr. Paul Arwater will be introduced further by Dr. Chatterjee before the evidence-based review. Next slide. So the objectives of today and the challenge with the therapeutics of COVID-19 are not binary. So it's not this works and this doesn't work. It's when does it work? How does it work? Who does it work in? What is the right dose for the right person at the right time? So this is a complicated discussion. And add to that, the numerous different therapeutics have been brought to the market because we all wanted a magic pill or a bullet that would save patients from dying. Unfortunately, that complicated journey is one that we'll discuss today. Many of you have joined us. So today we have representation from 24 states across India. If many people have not joined, please text your colleagues, get them online. It would be great for them to participate in this discussion. Especially a shout out to Andhra Pradesh, Madhya Pradesh, and Megaland, where we have like most of our pre-registrants from. We have a mix of workers. We have about 70 physicians, an equal number of nursing colleagues, and then other colleagues who provide services to COVID-19 patients. So for this audience, what we're going to do today is discuss the key evidence-based therapeutics currently available and recommended, understand those indications, which is really critical because these medicines may work, but not for all patients, and elucidate or elaborate on therapeutics that have shown no benefit. You know, doing more is not always doing better because it can sometimes cause harm. Without further ado, I'm going to hand over to Dr. Souvik Chatterjee, who is going to be your guide on the next 50 minutes.
Thanks so much, Bhakti. I think we've gotten a chance to introduce everything, and we're going to jump to our case. And I will say the one thing that I think we all feel from this pandemic is the overwhelming nature of both what it's mean for our lives and how it is to take care of patients. And we're going to try and narrow that overwhelming feeling down with a case. And then again, the key evidence-based reviews focused on therapeutics. So I will now turn it over to Dr. Ranjesh and Dr. Gothman, and we can get started with your case presentation. And I'll be very helpful in guiding the slides. So just let me know when you need to move forward.
Yes, please. Next slide, please. Good evening, one and all. I would like to thank the Johns Hopkins team and my professors, departmental professors, and Dr. Rajneesh Joshi, sir, professor and head of medicine, for giving me an opportunity to present a case in this webinar. Thank you, everyone. So straight away jumping into the case. Mr. Bhagat Singh, he was a 31-year male who was a truck driver. He did not have any significant past illness, and he did not have any comorbidities in the past. And he was an addictive of alcohol consumption for the last 8 years. He did not have any history of chronic liver disease. So from day one, he had a history of fever and myalgia since 21st of May 2021. So the total duration of stay of our patient in our hospital was 48 days. So I have divided the course of illness of the patient with a set of days in the upcoming 6 to 7 slides. So the initial 5 days course of illness, on day 0, he had fever and myalgia, for which he visited a local private clinic and where he was prescribed oral antibiotics and antipyretics, with which he was staying at home. And on day 4 of illness, he started developing shortness of breath, for which he visited the same private clinic, and he was found to be too much breathless. So he was referred to AIMS for further management. So on day 5 of illness, he got referred to AIMS. Next slide, please. Okay. So coming to the AIMS emergency room, that is day 6 of illness, he was found to be breathless, though he was fully conscious. He was a bit tachycardic and tachypneic with a respiratory rate of 22 to 25, and his saturation was 90% in room air. On an examination, he had bilateral crepitations. So with the suspicion of COVID, RT-PCR was sent with an nasopharyngeal swab. And as he was desaturating, oxygenation was provided with the help of a face mask with 5 to 6 liters per minute. And IV access were obtained, and blood samples were withdrawn for the complete blood count routine examinations. And in view of COVID suspicion, IV methylprednisolone 500 milligram bolus was given, and a third generation cephalosporin 1 gram of ceftriaxone was given stat, and a portable X-ray was obtained, which revealed bilateral diffuse infiltrates, which is quite more on the left side seen, which is on the day 6 of his illness. So on the day 6 of his illness, that is day 1 of our emergency stay, he had leukocytosis with the counts of 14,200. All his other complete blood count, renal and liver function tests were found to be normal, though his PF ratio was 220 on face mass 5 liters per minute. So he was shifted to the medical ward the next day, where his nasopharyngeal swab report turned to be RT-PCR positive. Next slide, please. So in view of COVID positive, the steroid was continued with 60 milligram BD for the next 8 days, and subcutaneous low molecular weight heparin, enoxaparin, was given in the BD dose, and the antibiotic ceftriaxone was continued for the next 4 days. So coming to the course of illness in the medical ward from day 7 to day 15. As soon as he got shifted to medical ward, he was receiving oxygen through face mask at 8 to 10 liters per minute with a PF ratio of 220. Over the next 3 to 4 days, his oxygen requirement kept on increasing, and his PF ratio was gradually dropping to less than 200. His ARDS was worsening. So on day 13, his oxygen requirement increased further, and his PF ratio dropped to 170. And so non-reservoir breathing mask of 15 liters per minute was given to the patient. And on that day, the ceftriaxone was stopped, and injection piperacillin tazobactam was added, and all the inflammatory markers were repeated, which was found to be quite high. CRP was 110, and D-dimer was ranging between 1,500 to 2,000, and he had a leukocytosis of 14,000. But still, his renal and liver function test kept to be normal. As his breathlessness worsened, on day 14 of illness, we got an X-ray which was quite evident of bilateral diffuse infiltrates, which is quite evident of ARDS, and his PF ratio had dropped to less than 170, for which we had put him on non-invasive ventilation on day 14 of illness. And as his breathlessness kept on worsening with a tachypnea of 35 to 40, so we planned him to shift to ICU on day 15 of illness. Next slide, please. So coming to ICU, on day 16, he was shifted to ICU with the non-invasive ventilation with the FiO2 requirement of around 60 to 70%, and his saturation was ranging between 90 to 94%. So he was continued on non-invasive ventilation for the next 2 days, and as his oxygen requirement has increased despite being received steroid for 8 days, methylprednisolone 60 milligram BD. So we had put him on IV remdesivir 200 milligram bolus followed by 100 milligram OD for the next 5 days, along with a tablet tofacitinib 10 milligram BD for the 5 days. And we had continued the steroids and low molecular weight heparin throughout the stay till the day 30. Steroids were gradually tapered, first 60 milligram BD followed by 40 and followed by 20. So after 2 days of receiving non-invasive ventilation, his breathlessness kept on worsening, and he desaturated to 75% despite being on 100%. So he was intubated. On the same day, he had developed severe shock, for which IV fluid resuscitation followed by vasopressor support were given, and he had a leukocytosis of 16,000. So the antibiotics were escalated from piperacillin tazobactam to meropenem and tigecycline, and it was continued for the next 10 days. Though he had shock throughout our stay in our ICU, his renal and the liver function test remained normal. So as soon as he got intubated, his compliance was very poor, ranging between 12 to 14. And his driving pressures were quite high, ranging between 23 to 26, with which we were finding it very difficult to ventilate his lung. So in view of PF ratio less than 150, so proning session was given, and the next 10 days he had received a total of 6 proning sessions, each proning session ranging between 16 to 18 hours on average. So the lowest PF he had on in the day of intubation was 60, and the next 10 days we could hardly achieve a PF ratio of 170 to 180 at max. We could not shift the patient for a chest HRCT thorax because of in view of worsening hypoxemia. So on day 10 of intubation, we had got a CT done, which was quite evident of bilateral extensive consolidation and fibrosis, which is more on the right side than the left side. You could see the consolidation and the fibrosis on both the sides of the lung. So in view of prolonged mechanical ventilation, tracheostomy was done on day 10 of intubation. Next slide, please. So after he got tracheostomized, slowly his oxygenation started improving. And on day 29, he started developing signs of hyperactive delirium. He was too much agitated, for which injection haloperidol was added, for which he responded over next 5 to 8 days. So on day 30 of his illness and on day 13 of intubation, his oxygenation kept on gradually improving. So we had started weaning in the tracheostomized patient. We were giving sedation only on an SOS basis. So weaning was initially started with pressure support ventilation and alternative TPs, with which we were finding very much difficult and asynchrony because of his agitation and poorly compliant lung. So intermittent high flow was given through the tracheostomy tube by removing the nasal cannula, just attaching the high flow through the tracheostomy tube. We tried weaning him, and over next 7 days, his oxygen requirement came down drastically and his compliance gradually improved. So on day 39, day 40, downsizing of tracheostomy tube was done to a 5 mm tube, and just oxygenation was provided with the TPs, and oxygenation was just provided with the TPs, and he was fully conscious. He had good neuromuscular power, and the cuff reflex was adequate. So after 4 days, the tracheostomy tube was removed and strapping was done. So we could see after strapping was done, he was kept on room air for the next 5 days, and as chest X-ray was done on the last day of his stay in our ICU, which is quite evident. The oxygenation has grossly improved, and his PF ratio had improved to 190. The PF ratio had increased to around 190, 200. And on day 48, we had discharged him from our ICU. So we could see the trend of compliance from day 1 to the day 48 of his stay in our hospital. On admission, he was having, on the day of intubation, he had a compliance of around only 12 to 14, which very gradually improved very slowly. And on the day of discharge, he had a compliance of around 24, 25, and not more than that. So after 10 to 12 days, he had visited us walking to our ICU just for a follow-up. And he was perfectly fine. He was not requiring any oxygen. Next slide, please.
So thank you. That was a wonderful case presentation. And I think so nicely highlights the spectrum of therapeutics available from antibacterials to steroids, to monoclonal antibodies to antiretrovirals, and the timing of when to get them. And also obviously a testament to incredible critical care that was provided to get this young man from near death to coming to visit your hospital as an outpatient. Dr. Rajneesh,